Good evening, everybody. It's great to be here with you all again today in the Jaypee sponsored program. A very important topic, what we are going to sort of talk about. It is about fever, whether it's friend or foe. What has happened is recent times. So what has happened is because of this media glorification of all the fevers around, whether it was dengue, whether it was malaria, whether it's COVID, the patients are really scared that when the fever comes, whether it's going to harm them, whether it's going to be a problem for their life-threatening illness, all those things come. Because what is happening is because of globalization, which India with never experienced the number of the types of fever. For example, hand, foot, mouth disease in children, whether it's dengue was not there. Then even your other malaria, many of the times because of our program, it had completely gone. Again, we are seeing leptospirosis, whether we are seeing rickettsia. These are the fevers we are encountering. But that's very important because in our practice, or even in your clinical postings in medicine or pediatrics, admissions, almost about 70% of the admissions are basically because of fever. So that's why it's very important for us to know, because what has happened is that the whole thing about the fever people have made it as a sort of a foe rather than friends. So let's go through next 1 hour whether we should know whether it's a friend or the foe. So I will just go through a series of case presentation, case scenarios and all that. So what I'm going to do is I'm going to talk about the basics of fever, what are the types of fever, the duration of fever, how do you classify it according to the duration of fever. So there are some practical aspects what you need to know about the fever as an undergraduate, because when you come to your internship, the basic thing you're going to handle it. And the most common is short duration fever, because PUO, paresthesia of unknown origin, a fever more than 7 days. Out of 25 cases, you may get one case of fever which is lasting longer than that. I'll go through some case scenario, interesting case scenario for you. And how do we control fever? Do you want the fever to be not to be there? Is there any medicine like a magic wand? You can just give a medicine that the fever goes away. No. And few very interesting take-home points we have there. So first and foremost, we should know why does the fever occur? Because when there is some germs, like for example, virus or bacteria comes into our body, the pyrogens release the cytokines. So when the cytokines, what it does is it goes to the brain and produces the hypothalamus to set at a higher point. Otherwise, what happens, our hypothalamus, as soon as the fever goes up, it sort of makes sure it is reduced. So what it does is when that happens, there is generation of heat and also conservation of the height, which is leading to rise in temperature. So how does it help? Whenever there is increased temperature, there is vasodilatation. There is increased blood flow. What happens is from the bone marrow, the WBCs, immunoglobulins, oxygen, nitrogen, everything goes there. And whatever harmful thing is happening, it will repair or the damage, the destructed, and destruct the infective agents like a virus or bacteria. But when does it come? Especially in pediatric, in a child who's less than 5 days, 6 months. What happens is they have 6 years. What happens is they can get febrile convulsion. So it is one problem. So what happens is the problem is virus is not a problem or bacteria is not a problem. Most often it is how our body reacts to it. You must have heard in the COVID time that there were a lot of cases of cytokine storm, which was resulting in the tissue damage because of the high temperature itself. How do we recognize a serious illness in a febrile child? Change in the look, activity is the most important parameter, not just the degree of fever. See, 105-degree temperature, child may be active, jumping around, but child is fine with 105, you need not worry. That means child is okay. The 100-degree temperature, child is not able to get up. He's lying down like that and he's not getting up, whining all the time. Then you should be more worried about this fever. So What happens? This is a sequence of event when the fever occurs. So as I said, these are the endogenous pyrogens, inflammatory modulators, immune reaction which is occurring, or it's an exogenous pyrogen or a microbial toxin which enters the body, which sort of affects the hypothalamic endothelium. Prostaglandin E2 is released, which elevates the thermoregulatory set point, heat conservation and heat production, which is resulting in fever. So one thing I would like all of you to know is that basically you should know there are 4 causes for fever. If you remember this, that is fine. Infection forms the majority case. There can be neoplasms like cancers causing fever, non-infectious like inflammatory causes causing fever, and miscellaneous like periodic fever, all those things, or a heat stroke. These are the other 4th type of thing. If you know this, you just have to look at these 4 things, and 70% of it almost is caused by the infection. So it's very important for us to document, because fever needs to be documented. Many a times there can be, mother may say there's fever, because what happens in a cold climate, her hands are cold, baby is sort of covered with warm clothes, so she will touch the baby. That what happens is that she feels that it is warm and she says the fever. Usually head is little warmer in small kids. So what happens when you touch the body and then the head, they'll feel that there is fever. So it is very important for them to tell them to make sure they buy a thermometer, digital thermometer, and educate the parents regarding how to take the thermometer. And encourage the care driver to record the time and degree of temperature. And you should insist that don't worry, fever 100, 101 is okay. Only if it is more than 102, then we need to worry. So let's come to what is the different types of fever patterns. We can say these are like what is called as a fever without focus. That is fever, temperature more than 100.4 or 38 degree is only presenting feature. They don't have any clinical symptoms or signs. Fever of unknown origin. Single illness in fever without the diagnosis after 3 weeks of outpatient treatment or 1 week of inpatient evaluation. That means you are going to do the test. Still, you are not finding the cause in a week's time. Then you call it as a FUO or a fever of unknown origin. Recurrent fever. Repeated unrelated fever resulting from infection of the same system. That means, for example, recurrent UTA. Child has got now after 1 month again. After 1 month again, or recurrent pneumonia, he can have periodic fever. There is what is called as a periodic fevers. This is the recurring episodes of fever. They have something like a clockwise thing. Every 3 weeks they have fever, or every 3 months they have now. It's a predictable interval, and in between completely well-being and blood test all will be normal. But they can have after ulcers. They can have a joint pain, they can have a rash, something like which occurs in the thing, occurs on a clinical basis. This is called periodic fever. And fever with duration, when you say fever, acute fever, it is less than 7 days. Subacute fever, it's between 7 to 14 days. And chronic fever is more than 14 days. So these are the terminologies which is there. So I've already told you about this, so I won't go through this thing. So it's very important for us to look at what is called short duration of fever, because 70% of your fever which comes to you because of short duration. Fever for 3 days, fever for 2 days, fever for 5 days, like that. So now you know short duration fever, when we say it is less than 7 days. So it is very important that we evaluate and rule out seriousness. If you have attended my earlier class where we said how to sort of evaluate the seriousness of illness, child who's fine will be jumping around and all that. So it's very important for us to take a proper history and a physical examination. Once you do it, you get a provisional diagnosis. He has got running nose, he has got little cough, he's jumping around. So your diagnosis is what? It's a flu-like illness, mild upper respiratory infection. Or he has got hepatosplenomegaly, he has got chills and all that, then you think it is malaria. You got a provisional diagnosis of malaria in an endemic area. Now, for the first one, what you will do, you will treat it. There is no need, because you know it's going on in the society or your community. you treat it with paracetamol and some decongestant. Whereas for the malaria, you need to document it. So what you do a malarial test, thick smear, thin smear, or FT. All those things we investigate and confirm that diagnosis. In flu, you don't need to confirm, or you have a follicular tonsillitis. There's no point in doing throat swab, getting a strep. Because most of it is streptococcus, you treat with antibiotics, no need to do the test. There is another category where you examined, but you have not find any provisional diagnosis is there. So when you have a child who has got a fever of short duration, no provisional diagnosis, because you have examined everything, but you're not able to find out whatever it is there. So no clear for focusing sign. So then you should think of whether I can wait. I can take the risk that this child is this, because child is jumping around, not looking sick. Then you need not worry. You just give a presumptive diagnosis of paracetamol and say, I'll do TCDC and whatever typhoid or whatever test is there. I can wait. Or malaria, or dengue, this thing, I can wait. But if the child is having some risk or a red flag signs, then you can give a symptomatic treatment, wait for the evolution. For example, if you see bacterial fever, it takes about 3 days for it to start focusing. When I say focusing, say, for example, he has got throat infection. For the follicle to appear, it takes 3 days. Fever, pneumonia to evolution of pneumonia to take place, it takes 3 to 4 days. So he'll start having cough, he'll start having breathlessness. It doesn't occur on the first day. UTI, he can get burning maturation only after 3-4 days. So that is, you are waiting for the evolution of the disease. But if there is, when you send them with the symptomatic treatment, when I say symptomatic treatment, so he's got burning sensation. You can send for urine culture or urine micro, but you can give a symptomatic treatment for the burning. What do you do? Alkalizing agent you can give and wait. But always remember this, that is, when you send on a presumptive or a symptomatic treatment, make sure that you tell them the danger signs. If it is there, you need to come back immediately, if not after about 24 to 48 hours. So any indication of seriousness, when the children come to us, what is very, very important for us, that is a fever which is not responding to all antibiotics. That is, even after giving paracetamol, if the fever does not come down, then you're worried. Now, any child who is less than 6 months, why? The child who has got less than 6 months, the chance of febrile, serious bacterial infection is almost 15%. Child with malnutrition, because their sepsis just spreads like this, septicemia, bacteremia, or immunosuppressive state, child on oncology patient on immunosuppressive drugs, on rheumatoid problems with and immunosuppressive, asthma, nephrotic, all are on steroids. Yes, you should tell them to come immediately. Or any change in the behavior. Child was fine, but somehow mother says, doctor, I'm feeling this child is sick. Child's urine output is coming down. Noisy breathing, breathlessness, or appearance of an unanticipated new child was there. Suddenly he starts having severe abdominal pain and vomiting. Then you should ask them, please come back. You need to evaluate properly. How can we come to a clinical diagnosis? See, now more and more tests are available. Our tendency is to write the test rather than take the history and take the do a physical examination. But that's a big burden on the patients, poor patients, to pay for such an expensive test. So it is very important that 85% of the time we can come to a diagnosis clinically and treat it as such. So analysis of the onset of duration and progress is the most clinical tool to diagnose the cause of fever clinically. How does the fever start? How does it progress? How long it has been there? This only will give rise to. Most common illness what we see is usually due to 4 things. That is viral, it can be bacterial, it can be malaria, or immune-mediated fever, like when we have this what we call as a Kawasaki disease or connective tissue disorders, or when we say a lot of this COVID-induced inflammatory problems. Bacteria can be bacteremic, which is already there from our own this thing, or somewhere point of it, say injury is there. If from there it goes. So that is the point of entry with that. And in our clinical practice, can we sort of differentiate between a viral fever and a bacterial fever? This is very important. You are sitting in your clinic and it comes, patient comes, can you differentiate? And you can save the costly investigation, and you can sort of a counsel and make sure the parents are happy. How do we do that? How does this viral fever present? How does the bacterial infection present? Usually viral infection, high fever at the onset, they will high fever. By third day, it starts coming down. And many of the viral fevers have biphasic thing. When I say biphasic, typical dengue fever. What happens? 3 or 4 days of fever, then there's a no fever for 2-3 days, then again a small spike of fever. That is called biphasic. Child will be non-toxic. When he has no fever, he's jumping around, running around and all that. Interfebrile period is absolutely normal. And usually he'll have multiple symptoms like running nose, cough, maybe abdominal pain, loose motion. You have a multi-system involvement in viral fever. Then more than one family, because if you see, it is usually in the community, it spreads from one to another. So you have more than one member of the family who's sick. Whereas bacterial infection, it will be a lower fever, moderate or mild fever. As third, fourth day, it starts peaking. Child is looking toxic. Interfebrile period, that even after giving the paracetamol, child is not very, child is not very okay. So fever will come down, but never comes down below 100. It will be around 100 and sort of be sick. And usually localized to one system or one part of one system. See, that is very important. When you say bacterial infection, you can't have the same bacteria in the lungs, liver, spleen, and all that. Usually, say it is localized to tonsils. So it will be only in the tonsils you can see the follicle. Urinary tract infection. And there is no history of sick contact. Whereas here in the viral, you have the community which is involved. And many a times regional lymph nodes are often enlarged because, say, you have a leg wound, your inguinal lymph node will be enlarged. Tonsils, jugulodigastric lymph nodes will be enlarged along with that. So the main thing about the fever is there are some basic things you need to do or ask the question. What are those? Degree of fever at onset. When the degree of fever is high at the onset of the disease, then you can make a diagnosis whether it's viral, malaria, bacteria at the site of injury, or it is immune mediated. If it is low degree of fever at the onset, viral it can be high or low. Chronic infection can have that. Response to paracetamol. So expected response to the behavior of the patient, that is more important than the fever coming down. That is, once you give the paracetamol, baby is fine, his behavior becomes fine, that's more of a viral. Whereas poor response is bacterial. Interfebrile continues to be sick, suggests that it is a bacterial infection. So rhythm, how is the rhythm of the fever? Whether it's rhythmic type of fever, erratic. Usually fever in malaria once in 24 hours, once in 48 hours, like rhythmic thing. By 3 to 4 days, worsening its bacterial infection, improving its viral infection, same it is malaria or immune mediated. Accompanying symptoms, if any, I told you. So that is very, very important, like running nose, cough, loose motion, all those things will indicate where the fever is. Focus on the first few days in PU. So pyrexia venosus, you need to just observe because the patient has been okay for 3 months. Nothing will happen to 3 weeks. Nothing will happen to him. Don't just start on antibiotic in this chronic or long time fever. So let me come to some of the case scenarios which is interesting to you. This is about a month back. I had 5 patients, all 2-year-old. All 2-year-old, 5 patients, different patients. They all came with fever for 4 days. There was no other symptom, only fever, no cough, cold, vomiting, loose motion. And I assessed them to have no risk at all. All were fine. Now, all 5 of them ended up having different diagnoses. How can you separate them clinically? It's very interesting. 5 patients, all 2-year-old, all with only fever for 4 days, no other symptom. The first patient, he had high fever at onset. It was a variable response or good response to paracetamol. Interfebrile period was normal. Fever comes every 5 to 6 hours. On day 2, cough, cold started. And day 4, the fever starts abating. This is a typical acute viral infection. Second patient, high fever at onset, poor response to paracetamol, interfebrile pain, he was still sick. Fever rises every 2-3 hours. On day 4, fever tend to be worsening. This is the time I looked at his throat. When he came to me first time, I saw a tonsillopharyngeal. There was follicles. Sometimes UTI also will present like this. Third patient, high fever at onset. Erratic fever irrespective of paracetamol. You give paracetamol after 2 hours, it increases. But sometimes you don't have fever for 10-12 hours. Interfebrile period, patient was normal. Same trend even on the day 4 also patient was continued. This is a typical malaria. This patient turned out to have malaria. Fourth patient, high fever at onset, fair response to paracetamol, interfebrile period normal. So he used to have 2 spikes per day. I observed for him in the next 3-4 days. Same trend continued. No other finding. His throat was normal, chest was clear, no hepatosplenomegaly, no lymph nodes, nothing. This turned out to be a rheumatological fever, or even in the immune response fevers, you can get like that. Patient 5, the last patient, he had mild to moderate fever at onset, initially fair response, but not on day 3. Trend of fever rising by day 3. Interfebrile period, he was sick. So in this type of fever, you get it in pneumonia, meningitis, typhoid fever. One thing I'll tell you, because you don't get pneumonia on the day 1, meningitis on day 1, because for it to body to get infection of the meninges at the lungs, it takes at least 3-4 days. So don't make a diagnosis of pneumonia or a meningitis in day 1 or 2 of fever. So this is a chart where you can make a diagnosis of looking at the blood, ordinary CBC, just one complete blood count, how the possibility of a infection, what type of infection can be made. This is hemoglobin, total count, differential count, neutrophils, lymphocytes, platelets, and all that. This is there. So I won't go through this because of time constraint, but you should know just looking at it. Looking at it, you can make almost about 90% certainty you can make the diagnosis. Now, CBC interpretation. So usually what you do is always when you ask for CBC on day 4 or 5, ask for a peripheral smear. If it shows neutrophilic leukocytosis with eosinopenia, which is a sign of either bacterial or viral infection, look at the focusing at day 3, you can make a diagnosis of bacteria. Whereas thrombocytopenia is more common with viral, malaria, and typhoid. And when you, because nowadays what I see, as soon as the patient comes and says fever, the casualty junior resident, what he does, he writes CBC, that this MP and all that whole, without examining or taking proper history. So you, when you ask an investigation, you should know what you want from that investigation. So when you have leukopenia, lymphocytosis, eosinopenia, thrombocytopenia, low is a possibility of a typhoid, you need to send a culture in the first 7 days. Widal test is after 1 week. You have anemia, WC pigment, thrombocytopenia, normal eosinophils on your peripheral smear. Then it could be malaria. So let's go through one more case scenario. This is a 4-year-old child diagnosed to have acute viral infection. Fever subsided on day 4, but recurred after 24 hours. What action we should take at this stage? So child was had fever again after some time. So basically what it is looks like a biphasic phenomenon. That is, fever came down, again he has got this thing. This is called as a biphasic. What action should we take? Fever moderate in intensity, but the child is drowsy. Child was fine, so it is drowsy now. Again, a biphasic fever, but second phase, what it is showing, that it is showing some complication. You understand? That is that why the child is drowsy. There must be some complication. So drowsiness is usually due to hypoperfusion and hypoxia. But he didn't have breathlessness, he didn't have cough. So unlikely to be hypoxic. It could be a hypoperfusion. So how does the hypoperfusion occur? Because of the loss of fluid in the third space. Possibly this child has got a capillary leak syndrome. So usually where do you get? You get a in dengue. So beware of unanticipated problems. It's very important that we have to keep a mind open. Behavior change is one of the most important parameters which is there. This is one more case. This is a 4-year-old child presents with fever for 5 days, excessive irritability, no other symptoms. On examination, everything is normal. In this child, how do we proceed? High fever, right from the onset, not localized days, so unlikely to be acute bacterial infection. Remember this. Bacterial infection, which is localized on the first day, very, very unlikely. Typhoid fever usually start with a moderate onset. Acute viral fever develops, but they usually have other symptoms like running nose, cough, and all that. So here we have a 5-year-old child, 4-year-old with a 5-day fever. So high fever from the onset. So this is what we call as a fever without localization. You have examined, but you have not find any localizing signs of that. But usually when a child presents like with irritability, usually what it suggests pain somewhere, pain without localization. It could be usually a bony pain or myalgia. Where do you get? You get leukemia is one thing. They have the bony pain. Think of leukemia in a child without focusing, which comes. Then Kawasaki syndrome. This is very common in children because we were missing a lot of this thing. They can have coronary arthritis and all that. We are picking up more and more. If you diagnose early and give the immunoglobulin, many of these children we can prevent this coronary arthritis from occurring further this thing. So when your child you have, the most important is how the child's well-being. He is comfortable, you are also comfortable. You just need to do a focus. This thing, you take the input from your associated symptoms. How is this setting where this child, from where he is coming, what is the immune status of the thing, and you can quickly assess the apparent level of sickness, whether the child is sick or not to sick. If it is sick, you need to admit and you need to put in all the investigation and take the decision what to do with it. And ask, is it safe to withhold antibiotics? What is the expected course of this illness? Do I need to treat? These are the 3 things you need to ask all this patient who comes to you. Okay. And coming to prolonged or recurrent fever, usually what happens, you need to make a distinction between the normalcy between a recurrent fever and a prolonged fever. So recurrent fever can be from the same system, or it from the different systems. Same system, usually pulmonary UTI. He's been having recurrent UTI, recurrent pneumonia. These are the ones. Second is like multi-system, recurrent viral infection, which is very common within the children. You can see that during the monsoon time, many of these children will come with a different viral infection. As soon as they get exposed to the school, they'll get all those things. Or you have a recurrent syndromes, which we said. This is what they call as a PPAFA. That is periodic fever. They have aphthous ulcers, stomatitis, pharyngitis, adenitis, etc. syndrome, which is there with them. So recurrent fevers, you need to differentiate recurrent versus persistent fever with the recurrent symptoms, and which will give a clue is the behavior, interfebrile episodes. What is the growth parameters? Again, one thing is that if it is persistent fever, his weight, his growth parameters will decline. He'll lose weight. He'll become malnutrition. Recurrent fever, which is not affecting, say, common viral infection, which they get in the school, their weight and all that will be normal. So it's very important. Every child who comes with this recurrent or persistent fever, you need to monitor the growth or plot the growth curve to see that. Recurrent disease, normal interfebrile, like for example, malaria, viral, all those things you can get with that. One more case scenario. This is a 4-year-old male who came with recurrent fever, 3 episodes in 2 months. So how do you do this thing? He gets in 2 months, 3. This is very common during monsoon season. That is, fever is moderately high, responds only to antibiotics, no other significant symptom. Last for about 3 to 4 days, subside after taking treatment from family physician. Interfebrile period is normal. So this child has had 3 episodes. Usually what is it? It could be most probably a viral infection. Recurrent non-viral relapse due to partial treated underlying cause. Like sometimes what happens, you give an antibiotic for 5 days, but the patient just takes for 2 days and if the baby is fine, and he'll say that baby is fine, stop the antibiotic. But after a few days again he comes. This can happen in malaria. Sometimes malaria, which is treated with not complete course, they can have a recurrent thing. Typhoid, they can be relapsed. These are the things what can happen with that. So just give me a minute. I have one more child who's got 4 years, recurrent fever, 3 episodes in 1 month. So fever is moderately high, respond only partially to antibiotics, no other apparent symptoms, last for about 3 to 4 days, and subside after taking treatment. Intervening period between the fever episodes, child feels tired, not very active. He feels tired, he's lying all the time, whining, crying, and gets attached to the mother. So your analysis, this child has got recurrent fever. Personal history during intervening period is abnormal. That is, he's sick. He is all the time lying down, not active. He was playing outside every day. Now he doesn't want to go. So in this case, you should think of it as something more than that. Why does he get 3 episodes in 1 month? It could be leukemia, Hodgkin's lymphoma, or something like that. So some of the fever rules that provisional diagnosis possible even without a physical sign. Just take the history and you can come to a provisional diagnosis. History will give you 70% of the diagnosis. No fever. Remember, don't put antibiotic for a child without fever. No fever, no bacterial infection. No antibiotic for first 3 to 4 days of fever till the disease localizes. Like for example, tonsillitis, dysentery, lymphangitis. You see it, that's a localized. There you can treat. If empirical antibiotic has to be started, send some relevant. Always when you want to start an antibiotic, please send some basic investigation before starting. Drug resistant is rare in community. So don't use higher antibiotics. Amoxicillin, it still works wonders. Use that. Rationally selected antibiotic fail, look for an alternate diagnosis rather than using a second antibiotic. If your clinical diagnosis is strong and if you feel that it is not improving, think of another diagnosis rather than putting second antibiotic. If 2 antibiotics fail, acute bacterial infection is ruled out, do not try for the third antibiotic. That is, if there is 2 antibiotics, child is not responding, do not try the third antibiotic. Antibiotic is not acting. Let me try this. Let me try. Many times we see this prescription. The patient keeps on getting 5 antibiotic in 2 weeks. Rationality is important, endowed by reason. Because if you have the rationality with reasoning, you can make. It should be an integral part of a noble profession. That is rationally with the reasoning, common sense. If you treat, that's the best part of this thing. Present scenario, what do we see? You see the prescription of so many doctors. It is irrationally rational. Our number of drugs is more than we write more time writing the medicines than giving time for a patient or explaining to the patient. Is it really possible to be rational, and how? If you have confidence, if you have time to talk to the parents, you give more time to them, explain why does the fever comes, how does the fever be there, what are the danger signs in fever. There is no need for you giving antibiotics. This is very important. History taken properly gives 85% of the diagnosis. Physical examination hones it down to 95%. And labs are just needed, confirm the diagnosis, not to search for the diagnosis. Now what happens when you come to the ER? As soon as you take the fever, 100 tests are done immediately. without even examining, without even asking the questions. So is it really possible to be rational? How? We should be able to diagnose this correctly, because our clinical science, beautifully written by Hutchison and many of them, this thing, if you put in your mind to it, if you take a proper history, do a physical examination, you can make the diagnosis clinically 95% of the time. History, components of diagnosis. What you do is, whenever I get a patient, I think of four things, because what is the anatomy of the disease? He has got cough. What I feel is that, okay, he has got either in the throat or in the lungs. That's the anatomy. If he has got jaundice, my anatomy is liver. Pathology, what has happened? He has got cholestasis. That's why he has got jaundice. Or he has got hemolysis. That's why he has got jaundice. That's the pathology of it. That is pathology. For example, he has got asthma. What is the pathology? It is because of bronchospasm. That's the pathology. When he has got wheeze, where's the anatomy? It's in the lungs. He has got the anatomy. What is the etiology? In asthma, what is the etiology? It is allergy. That's the allergy. Then what is the malfunction? In asthma, what happens? He starts breathing fast. He gets hypoxic. That's the malfunction. When you get hypoxic, what happens? He becomes respiratory failure. He can go in for. See, if you can, every patient you comes with a complaint, if you think of this in the history, that is anatomy of the disease, pathology of the disease, etiology of the disease, and malfunction, you can make a diagnosis so easily. Diagnosis of acute bacterial infection, not always easy. Fever is essential. Some expansions like newborn and all this thing, you need to treat as early as possible. Other causes fever need to be examined, like infection, parasite, non-infective causes. This is very important. Remember, malignancy, collagen, central nervous system. I had a patient long time back who had met with a road traffic accident and had injured a hypothalamus. So whenever she used to get fever, it just used to rise because the thermostat had lost. She would get 107, 108-degree temperature with rhabdomyolysis, which is going into acute renal failure. Heat, pyrexia, heat hypopyrexia in some of the places where the temperature goes above 48, 50. Drug-induced fever. These are the non-infective fever, which is important. So coming to the diagnosis of acute bacterial infection, fever is not an antibiotic deficiency state. Don't think every time you get a fever, it is antibiotic deficiency state and you give the antibiotic and the patient becomes well. Remember this, a good doctor is the one who makes a diagnosis and gives least antibiotics as possible. Greater accuracy than lab test, because your clinical history, your clinical physical examination is much has got a better accuracy than the lab test. Onset and the duration of progress of a child illness gives far more information than any lab test. Fever pattern is the key to the diagnosis. Approach, it's very important for to rule out the seriousness, look for the localization, assess the progress of the fever, reassess periodically, and search for the non-infective. These are the 5 things we need to always look for. So, point pattern, autoimmune disease, what happened? Fever without localization, which goes, I would not go into this data. When do we suspect a non-infectious disease? Duration, child is going on happening. Trends, how the fever, like accompanying symptoms are there. When do you suspect this non-infectious fever? Rash is there, joint swelling is there, bony tenderness is there, night sweats are there, ulcers are there. Then you should think of all this inflammatory diseases, oncology patients, and periodic fever. And behavior during and in between the periods are there, fine with that. Anthropometric, a child who has got infective fever will definitely have his weight, growth parameters reduced. So make sure the anthropometry, you sort of a plot is growth curve, recurrence. These are all this thing. Vasculitis, you can see this vasculitis which is occurring. One more thing, what you can think of is a drug-related hypersensitivity syndrome, especially ones which is anti-epileptic drugs or dapsone. They can have fever, rash, lymphadenopathy, hepatosplenomegaly, hepatitis, thrombocytopenia, eosinophilia. This thing you should keep it in mind. Kawasaki, I've already mentioned. It's a great mimic. Child is sick, irritable. Think of Kawasaki in a child who's coming with 5 days of fever with the single lymph nodes. peeling, conjunctival injection. Always think of that. Huh? So PUO, FUO or PUO in pediatrics is more likely a usual presentation of common disorder than a common manifestation of a. Remember this always. It's always look for a common disorder rather than uncommon. So this is about that percentage. Infectious disease about 60%. Hemato-oncology about 5 to 10%, rheumatology about 10 to 20%, undiagnosed self-resolving about 10. This is the amount of percentage of causes or etiology of fever, what we get that. So some tips, longer the duration of fever, infections are unlikely. Lymph node pallor, splenomegaly is common in infection and neoplasm. Rash anytime, any type, usually it is rheumatology or zoonotic type of infection. Follow every lead, whatever minor, even a smallest thing. When your fever is not subsiding, instead of putting another new antibiotic, if go back and take a proper history, you will get a clue for that. Share responsibility, because when you don't know anything, you can ask some other people who have got experience to come and give their opinion. Think TB, but don't be frantic. Any child who has got fever, don't try to put on clinical trial of medicine. And there is a lot of this thing, because as we invade our forest, as we get into the space of our animals, we are going to get more and more zoonosis, more and more trekking. We go into their habitat, adventure. We are going to get more and more of this thing. There's no fixed protocol to suit all patients, so individualized approach depending upon the clinical flow is very important. Always, when you do the investigation, proceed from a non-invasive investigation to the invasive one, as we are this thing. This is the last case scenario, that is 15-year-old, prolonged fever, no history of weight loss, several lymph nodes in the this thing, no tenderness, rubbery. All those things. They thought of all these things and did the investigation. Every investigation, everything was negative except Epstein-Barr virus was positive. Every other investigation was there. Then we do the chest X-ray, did a CT, we did a lymph node biopsy also. Lymph node biopsy showed Kikuchi's Fujimoto's syndrome. I'm just put this because sometimes we get an exotic diagnosis. But never think of this exotic diagnosis. Don't always think of obsess with this. Sometimes you need to investigate, you'll get this surprise in your thing. So finally coming to algorithm, that is, we have to think, is there fever? Primary probable or established? Yes, if there is fever, treatment started. If the persistent fever more than 48 hours expected in this child, you have to explain to them. Yes, counsel and observe. No, is your diagnosis correct? Is there any complication developed? That's why the fever is continuing. Is the resistance is the issue is one more thing. No, suggestion of anatomical or etiological rejection. Is there this thing? You have, I can hear a bronchial breathing, or I have a cough. I have jaundice. So is it showing anatomical or etiological localization? If yes, search by doing the investigation. If no, then you just have to take the history again, do a proper physical examination, think of second opinion with the ID specialist or rheumatologist. Control of fever. So which fever needs treatment? It is not the fever that needs treatment, but the associated discomfort. Everybody thinks we are giving fever medicine to decrease the fever. No, we want the patient to be comfortable. That's why we do. How does it, this thing, it's only need to be given paracetamol. Occasionally ibuprofen. In which clinical situation we do not wait and watch. It is at less than 3 months. Immunocompromised children, normal malnutrition, we need to admit them, do the investigation as well. So method to bring down the fever, last part of it, that is physical methods like antibiotics. Two things we can distinguish, physical methods and antibiotic. Physical methods by tippage sponging. Don't use ice cold water, use just a tap water. You can give bath, you can use this thing. There are many this thing like paracetamol, mefenamic acid, ibuprofen. I'm very discomforted. I'm discomforted by seeing the prescription, that is 6 times paracetamol, 3 times mefenamic acid, and SOS ibuprofen. This is what the prescription says. You need not give something like that. These are all there, but to give a proper dose of paracetamol, 15 to 20 milligram of paracetamol. Mefenamic acid, it's an anti-inflammatory one. Second line should be always ibuprofen, not mefenamic acid. So management, older children, document properly, give a lot of fluid for the thing. Overclothing, don't cover when you've got fever, let it dissipate. Use an antibiotic, tip sponging, explain the red flag sign, close follow-up, monitor the vital sign, specific treatment if it is there. So fixed dose antibiotics are irrational. Either combination of this thing, many of the people have come out with two antibiotics, paracetamol, ibuprofen, paracetamol with mefenamic acid. It's an irrational combination. So please don't use it. Use one drug in a proper dose. Route, like for example, it has been shown paracetamol suppository or paracetamol oral has got the same effect. But ease of administration, child is more vomiting, you can use the suppositories. Coming to the key message, let the disease evolve. Let the infection localize. Don't be in a hurry. If the patient is fine, let the infection localize. You'll know that infection and you can treat. Identify and stabilize the sick child. That's very important. Use single antibiotic, which is narrow spectrum, paracetamol for the fever. I won't go through this detail. In conclusion, fever is a friend. A disease-causing fever needs recognition and treatment, not suppression of fever. You don't have to be scared of fever. You're a doctor. You wait. It doesn't need immediate treatment if the child is fine. Does not suppress the fever every time. Documentation of the fever is the most vital. Analyzing fever based on the six of the question which I told in the initial gives diagnosis for almost 95% of the cases. Discomfort due to fever needs treatment, not the fever itself. Drug to be used is only paracetamol. No antibiotic should be given unless the diagnosis. You see the focus of infection. You see the follicles. You hear the crepitation. You see the otitis media. Then only you give it. In infants less than 3 months, immunocompromised child, malnourished child need early workup and treatment immediately. Finally, when in trouble, take the history like a first year UG, examine like an exam going PG. Look for the clues like Sherlock Holmes, because if you see, Sherlock Holmes was one of this thing. Because if you see Sherlock Holmes, that whole novel was written by a doctor, and it depended upon his professor, who was a physician in Edinburgh. So he observed like how that his physician was diagnosing the disease. That gave him an idea to write the Sherlock Holmes novel. Remember, most of the children we see have not read Nelson or your Hutchison or Davidson. They often present atypical. Please maintain faith in clinical. You believe in yourself. Believe in your judgment. Think of the cases what you have seen in your undergraduate days. And finally, thank you very much for patient hearing. Thank you.